Hi everyone, I'm Dre, the host and founder of the Dragon Network. Welcome to this week's video. For today's video, I want to switch it up a little bit and I'd like to talk about one of the physician payment reimbursement models called capitation. So capitation is probably a term that you've heard before if you're working in the healthcare space. It took me a little while to figure out all the different ways that it was interacting with our health IT systems, and I thought I would sort of share what I've learned so that if there's anyone else out there that felt like I did a few years ago, this might help. So while we hear about capitation-based payments in association with US-based healthcare conversations, the model actually exists around the world. So what capitation is it is actually a predetermined rate of reimbursement that is allocated to a provider or to a provider group to cover the costs of care for a participant or for a patient over a defined period of time. The individuals that are covered under these capitated-based payments are often referred to as covered lives. So base capitation rates are set based on particular service types. There are often adjustments made at a per patient level to account for comorbidities or external factors that are likely to increase the cost of care. So for example, if you are looking at a country with capitation models across broad breadth of geographical area, you may have different base payments, not only based on the patient's comorbidities, but also based on the locations. So before we jump into how capitation relates to IT systems, we're going to go over the 4 different types of capitation models that are present. The first one is called global capitation or full capitation, and it actually will encompass all services that are to be provided within that time frame. And by all services, I mean all of your diagnostics, your labs, your physician visits. Often they also include your medication. So anything that is going to be encompassing for that particular service, for that patient, for that time period. The second type is partial capitation, sometimes referred to as blended capitation. So this model will cover the services and some of those ancillary supports for some things, but not everything. For example, you may have all of your preventative care and your urgent care covered, maybe even your emergency-based care, but inpatient care as well as some specific diagnostics or specialty type cares would be outside of the capitation model. So the third one is primary capitation. So this would cover all of your services that are associated with primary care. And this one is quite common in a number of countries around the world, definitely common within the US to have reimbursement models that are focused on primary care services. The primary care services aren't necessarily just by a primary care physician. They also can include the lab costs, some of the ongoing medications that are required, as well as some of your diagnostics. So this model does require that everyone who is in that covered life category have a primary care physician identified, and there is a fairly large assumption made that you will go to the primary care physician for all of your primary care needs. So the last one that we'll touch on is secondary capitation. So secondary capitation also requires that you have a primary care provider, but it doesn't just include the primary care services. There's also some negotiated services for specialized care that are actually connected to this particular model. So with this model, you may also have mental health services, social work services, pharmacy consultations, as well as your labs and diagnostics. There may be other specialists that are brought in or that are negotiated into the group. So this secondary model really is bigger than just your primary care, but forms a network where the covered cost is going to look after everything that occurs within that group or within that provider conglomeration for the particular patient. So in general, the concept of capitation gives the impression that the physician and the patient are going to have more flexibility in determining what care is required. So there isn't that cost that's associated with everything like there is with the traditional fee-for-service model. So there should be some more flexibility in making the decisions, and there is an argument that that flexibility will allow for better care to be provided to the patients. However, with the capitation model, there are some challenges, and this is where we start to see sort of the IT piece rolled in. Because the capitation payments are based on the number of individuals that exist within that ecosystem, there is a strong drive to have as many people in that ecosystem as you can and to focus on maximizing the profitability with those capitation payments. So the payments are set at a base level. So there is a drive to decrease the actual spend that is needed per patient. So there's a pretty big drive in capitated model reimbursement to go after the population as a whole and to try to reduce the amount of cost that's being spent for things that are going to impact the most lives as possible. You'll start to see a lot of focus on these organizations requiring reports that are at a population level. So some of the data repositories, some of the analytics that come out, some of the reporting capacity would be on that broader population base, and population health really begins to take sort of a focus and be in the forefront here. One of the other big things that impacts IT with a capitated model is, like I mentioned earlier, there are risk adjustments that are made for comorbidities or for external factors that are actually going to or likely to increase the cost of care for a particular patient. So there is an extremely high incentive for all of those comorbidities and all of those factors to be accurately documented in the record so that they can qualify for that higher base pay. So the plain regular base pay for a healthy individual, sort of middle-aged, no comorbidities, is very different than the base pay for an individual who has several underlying conditions. So in order to make these risk adjustments, the IT systems are frequently asked to have a heavier focus on capturing what these comorbidities are and tracking them over time, and making sure that the comorbidities are documented against or are connected to every single care event that occurs. And that's so that the rate for the patient can be at a higher base level, thereby increasing the profits for the organization. So this isn't necessarily a bad thing. Those higher capitation rates are developed for the intent of being able to adequately care for individuals with comorbidities. So it is a good thing for us to have everything documented and to properly maintain it, and for the provider groups or the providers to be focused on making sure that care is actually being given for the entire patient history as opposed to just one particular event. So the last thing I'll mention from an IT perspective with a capitated model is that there becomes a very strong incentive to try to keep the individuals inside of the organization. So if an organization is being paid for a covered life, and that covered life goes outside of the group or outside of the organization for a service that should be included or is included with the capitated payment, then the organization needs to pay the other service provider for those services, or to have that amount sort of reduced from the capitation payment that they're receiving. So they aren't going to get paid for something that someone is intentionally seeking elsewhere. So there's a very strong incentive to keep those covered lives seeking care and receiving care within the model that they're being paid for. So with this, what we've seen is some more merger and acquisition activities that have occurred. We've seen some health IT related workflows and analytics and business intelligence that is focused on understanding sort of where patient follow-ups are happening. We've seen more touch points that are occurring between the provider group and the patients. So trying to keep the patients within the existing ecosystem. I recognize that the reimbursement models are typically focused on the revenue cycle side, but I wanted to touch on them here as they relate to the other areas, just because I do think it's very important that we understand sort of why there is focus, where there is focus, and how the rev cycle component and reimbursement is actually factoring into that. So there are certainly other things that are occurring in the fee-for-service model or in the ACO models that I may create other videos for going forward. But this one with capitation tends to come up fairly frequently because a lot of individuals who are just entering the field or are starting out their careers in healthcare IT aren't quite sure what a capitated model is. And if this is actually a topic that you'd like to hear more about, or you'd like to know more about payment reimbursement models in general, let me know in the comments. If you aren't a subscriber yet, go ahead and hit that subscribe button and turn on your notifications. And I will see you again next week.